Hi, I'm Frank Diamond, the managing editor of Infection Control Today. With me today is Dr. Brent James, an internationally known expert on the clinical quality and patient safety. Dr. James is a clinical professor at the Clinical Excellence Research Center, Department of Medicine, Stanford University School of Medicine. Dr. James was at one time the Chief Quality Officer and Executive Director of the Institute for Healthcare Delivery Research at Intermountain Healthcare. He knows about both the provider and health plan side. In other words, today Dr. James is going to talk about direct-to-business arrangements. In those arrangements, large employers or groups of small employers, consortiums, contract directly with healthcare systems, cutting the insurance company middleman out. This is a fairly recent phenomenon and it seems to be growing. Dr. James, thanks for being with us here today.
A real pleasure to be with you, Frank. I'm looking forward to the conversation.
And if this is not the first time you've been with us, and we're always happy to see you at Infection Control Today. So direct-to-business arrangements, what are they exactly, and how do they come about? And they are. You mentioned that it's a fairly recent phenomenon.
Yeah, there are two elements to it. Now, the second one's going to be you have to be able to manage care, but let's come back to that one in a minute. Why did they set up in the first place? You know, the best way I know to introduce it, some years ago, I was asked to chair a strategic planning committee at Intermountain. Eventually, it produced our population health initiative. In the committee, I had senior executives from across the system, including the three senior leaders from our own health plan, Intermountain Select Health, the largest commercial insurer in the region. I had the CMO, Steve Barlow, the COO, Lisa Fowler, and the CFO, Mark Brown. Well, as we were working our way through, I asked the question. I said, exactly how does an insurance company add value? We came up with a list of 10 major items, lots of smaller ones, just to give you a flavor for it. They do something called transaction processing, insurance claims processing. Surprisingly difficult, by the way, real expertise around that. Actuarial risk analysis. Part of that is reinsurance. When do you reinsure a patient for really high cost patients? They did a certain amount of benefit design. They did a certain amount of customer support. Oh, a big one. They did network formation, where they found a sufficient number of hospitals, clinics, physicians to supply all health needs for an insured population. And the list goes on. Yeah. When we did the analysis, the thing that we found is, number one, almost all of them were available as commodities in the general market. You could purchase them, outsource them, the claims processing, the actual risk analysis, for example. You could purchase them at very good prices, competently done in the external market. The only element that they couldn't outsource was network formation. But we realized if the system were large enough that it could form its own networks, that it had a sufficient blend of physicians and facilities, that they could handle that on their own. The second piece, we came back next and said, all right, given that this is the value add, how much should it cost? We expressed it as percentage of the premium dollar. The answer we got was between 4 and 8% of the premium dollar. Seemed low, but I checked in our community. We had a number of nonprofit insurers, DMBA, that's the LDS Church's self-insurance plan, PEHP, Public Employees Health Plan. It's a consortium of public employee groups from around the state. Educators Mutual for school teachers. They were all running at about 4%. That's roughly where Medicare runs too, just in passing. So it turns out the 4 to 8% estimate was pretty reasonable. Oh, the trick. Major for-profit insurers pull somewhere between about 15 and 20% of the premium dollar to put onto their bottom line in the stock market. And it was that difference, let's say between 6% and 18%. 12% of the premium dollar is a lot of money,
right?
You see. And that was the economic argument that if a large integrated system could go direct to self-insured employers or RISA plans, that they could then, through negotiation, decide how to divide that pie of 12% of the premium dollar. Now, frankly, given that it's the health system that puts it together and the health system that has to do the care management within it, I'm prejudiced. I think it ought to swing a little bit more to the care delivery system side. But that's what made it so very attractive. Now let's shift gears and go to the other side, the care management side. A lot of insurance companies claim that that's how they added value, that's how they justified the additional spend. The fact is, we had proven that care management works much better at the level of a care delivery system than at the level of an insurer. And we had hard data showing that. Makes sense. It happens better if it's closer to the point of action where a patient interacts with the system, and the insurance companies are kind of two giant steps away. So we knew that. Oh, if you start to manage care, that's where you get into the whole population health thing. We estimated that we could drop the cost of care by 30 to 50%. Mm-hmm. So you've got the, let's say 14% here, but then you've got over here, you've got waste elimination through better care management. The cool thing about the waste elimination, the way you get it is to improve your clinical outcomes. So the money aligns to your mission, better clinical outcomes, lower costs, and it put an even bigger pot of money to share. Now, I saw quite a number of cases where, well, a classic, it was an infection control case, patient who went in for open heart surgery. They developed an infection, a post-op infection from a staph epidermidis, a common bacterium that lives on everyone's skin, usually completely innocuous. This was a strange variant. The patient had a very fast, bad course and died. Shortly after he died, his estate sued the hospital and the physicians because we didn't prophylax staph epidermidis, right? Turns out it was right in the protocol. They had a list of organisms that we did prophylax. They had a list that they purposefully did not. And it turns out that we had the evidence-based best standard. It doesn't say you have to do everything. It just says that you deliver good care. And by consensus in our infectious disease led, but consensus among our physicians and nurses, that was best care. And what we did is we pulled out the protocol and then showed it to the plaintiff's attorney. Once again, another lawsuit dropped fairly quickly before you go through all the trouble of preparation. That's where the real money goes, by the way, is in discovery and preparation. We had a long list of those cases. Now, imagine the opposite happens. Imagine you have the standard and you need to vary. All right? Well, two things. We had built into every protocol, it was just boilerplate. Our attorneys had helped us with it. It said, this protocol is designed for the general use of most patients, but may need to be adapted to the specific use of a particular patient by the patient's caregiver. All right? It was right there in the protocol. It was honest. It's exactly how we used it. It also became number two, that's when you need the note. Right. When you need that six-word note is when you choose to vary, right? And you just need a clinical explanation, but it became a marker. Oh, this is where I need the note to protect me, you see. I have to tell you, honestly, on long experience, it reduced our malpractice risk because it established a legitimate written standard of care, and it told us when to document. So on net, our malpractice risk went down.
What about defensive medicine? I mean, I think once you're a doctor, you know better than I do. I mean, once doctors start practicing in a defensive way, or any healthcare professional, infection preventionists or nurses or anybody in the hospital, I guess it's a hard habit to break, or does this help them? Does this give them more breathing room? Does this make them feel that they can?
Yeah. Well, so there are two elements to that too, Frank. The first was this. What turned out was happening, we investigated this a bit. So you measure variation in care. One guy's doing it one way, another person's doing it a different way, third person's doing it yet differently still. And we go back and ask them, why? Why did you do that? And nearly always they'd come back and say defensive medicine. It was a really common response. What we discovered, though, is that it probably wasn't defensive medicine. It was just plain old garden variety variation. I was doing it, in my opinion, with very little support, right? Mm-hmm. So it was a marker for variation, and it probably wasn't a legitimate answer, to be honest with you. It's just a handy hook to hang your hat on when somebody challenges you about why you're doing this thing this crazy way, you see. Well, that kind of went away, but you have to give that pressure relief valve. On average, you know, we did this for over 125 protocols. You'd vary about 5 to 15% typically. I used to say it this way to my colleagues just to make it real. I'd say, look, guys, we're tracking protocol variances. You will get as much scrutiny for complying with one of our protocols too much as for complying too little. If you're different from your colleagues, we want to take a look. The first time that really played out was in infectious disease. Interestingly enough, John Burke, head of infectious disease, had a system. It's called antibiotic assistant. So if you had an inpatient who developed an inpatient infection, it was like you got a consult from ID in about 3 or 4 seconds. You just called up the program. You told it assumed you wanted the patient in the bed next to the terminal, but you could tell it differently. It assumed you wanted a 1-year time frame. You could tell it differently. You had to tell it the sites of infection you were interested in, but then it did an epidemiologic evaluation of that patient. The first screen listed, here are the most likely causative pathogens in our experience at this hospital. So it'd give you a differential of causative pathogens. So there's a 72% chance it's this one. Oh, with this pattern of sensitivities, there's a 59% chance it's this one. There's a 31% chance it's this one, with each with sensitivities. In priority order, I mean in probability order. If you went one screen ahead, it said, here's the best antibiotics to treat this set of infections. It actually gave you several choices. It was in priority order by efficacy number 1, and then if it had several of similar efficacy, it had prioritized them in cost order. And if you saw one you liked, give me number 2. 2, return. It ordered the drug, it alerted the nurses. If you had level testing, it automatically did the level testing. Now, initially, people were really kind of, you know, how to say it, watchful around this thing. Did it deliver good care? As you would expect from any good group of clinicians, but it turned out it worked, and it worked pretty well. The real problem is 2 months later, they came to us and said, you know, we don't really need to see the differential. Just show us a list of antibiotics. It'll shorten our time. And then they came back and said, don't show us the whole list of antibiotics. We pretty much always want the one on the top. Just show us the top one. It reduced it to a single click, single return. And it took the time that when I was practicing surgery, it used to take me 10, 15 minutes. It probably cut it by half. You see, that was really popular. But then we saw the downside. The downside was John, using the same system, started to pick up cases where they should have buried and didn't. We'd made it so danged easy to follow the protocol that, you know, people weren't thinking as hard as they should. But it turns out the same system that detected it. So at the time at LDS Hospital, you might get a consult from ID even if you didn't order one.
Right.
Because John was monitoring the whole hospital, and he'd come by on cases that looked like they needed a little expert oversight and just show up. They learned how to interact with their colleagues in a positive way. What we saw, by the way, this was published in New England Journal of Medicine, is a rather dramatic drop in, well, it was infection-related mortality is what they were tracking in that study. And side by side with it, a drop in cost. I love the way that Dave Class, one of our ID docs, said it. He said it was more targeted therapies where you were getting the right therapy to the right patient at the right time. If you see what I mean.
Yeah. So, okay, Doctor, anything you want to add that I neglected to ask that you think is pertinent to this conversation?
You know, I've been looking for my whole career for things that make this happen faster and better. Time after time, I've seen it dramatically improve clinical outcomes and reduce costs. Sometimes it's a real uphill fight. And frankly, on my side, it mostly has to do with administration, worried about their revenues. When you move into these direct-to-business relationships, technically it's a form of shared savings. And it solves the financial side so that medically we can do what's right. And I'm pretty sanguine about it. I like it a lot. I think it's a good way to practice medicine. It will make us better doctors, help us learn faster, and help us deliver dramatically better care to our patients. I hope it takes over the world. And I think that all of us should, and I think it will make us better doctors and a better practice in general.
Better for infection prevention.
Oh, yes. Oh, yes. The examples I just used were all infection, weren't they?
Yeah. Yes, it was. Dr. Brent James, as always, a pleasure to have you here on Infection Control Today. Nice again for joining us.
Well, thank you very much. Oh, by the way, it works even better outside of infection control for old surgeons like me to help us improve our practice too.
Okay, Doctor.